minimize this. So a person comes in, 57 years old, that looks like this. And I know if I were to ask my residents how to describe these opacities, I would get a lot of variable observations. So like reticular, ill-defined, nodular, reticular nodular. Sometimes they're not quite sure what words to use, particularly the younger residents, whom I haven't had a chance to influence yet. In terms of negative statements, the heart's normal in size, no findings to suggest lymph node enlargement, no pleural fluid. So here is the CT on the same day. See, these are from the outside. So this confirms that what we're looking at are septal lines, florid interstitial lung edema in the form of septal lines. In addition to septal lines, I read a description from the outside, which I'll show you, from the outside assessment, outside hospital, in which someone decided there may also be tree and bud opacities. There aren't any. Perhaps some of these ill-defined nodules were interpreted as such. I'm not really sure. But this is a great example when we see these opacities, oval-shaped, and then these rounded, of what we call septal lakes. So this is florid interstitial lung edema, and these opacities are not a separate nodular pulmonary disease. This was initially described in a paper from Belgium as lymphatic pearls. We decided it's unlikely that these represent fluid distended lymphatics, but rather fluid distended interlobular septa that produce these nodular opacities. Other signs of interstitial lung edema, florid peribronchial fluid cuffs down here. And we also have pleural fluid, small, right more than left, and an esophageal hiatus hernia. So, in summary, the findings are those of florid interstitial lung edema. Let's have a look at the mediastinal fat, by the way. Now, we don't really have waterlogged fat. We don't really have lymph node enlargement. No evidence of pulmonary embolism, of course. And again, no chamber enlargement. So there's no reason that this should represent cardiogenic edema, but florid interstitial lung edema. So typically, I teach that when you have, and of course it depends on the acuteness of the situation, but if you have florid interstitial lung edema, and you're thinking that this isn't hydrostatic lung edema, then some unusual things should come to mind. And among those, I teach the possibility of pulmonary veno-occlusive disease, tumor obstruction of pulmonary lymphatics may produce interstitial lung edema. But this patient does not have those. So any other thoughts before I give you the history as to the etiology of the florid interstitial lung edema? Or any other things that you typically teach your residents when it's not left atrial hypertension?
Well, you could have veno-occlusive disease, right?
Pulmonary veno-occlusive disease, yep.
So something, yeah.
Just an acute MI. I don't know if you mentioned what their symptoms were. I came in halfway through, but I always look for.
Yeah, I'll show you. So that would be in the category of left atrial hypertension from cardiac disease, acute MI, but that's certainly a thought. And of course, yeah, you may not have cardiac chamber enlargement in a patient with acute MI.
Yeah, the left atrium does look a little small, right? Yeah, or
at least
normal.
Not enlarged. Yeah, not enlarged, right. Yeah, so we've mentioned pulmonary veno-occlusive disease, the unusual circumstance of obstruction of pulmonary lymphatics by tumor cells manifesting as florid interstitial lung edema. So here the
I don't know, like transfusion or something like taco,
transfusion-associated acute lung injury,
or just
possible.
circulatory overload like taco.
Yeah, suppose before you get alveolar edema, you might go through the stage of severe interstitial edema before you get alveolar edema. But usually with transfusion associated, it's a form of acute lung injury. So typically I would expect not to see just interstitial edema, but also some alveolar edema. And Travis, I did mention maybe perhaps before you joined that we have a wonderful example of the septal lakes of interstitial edema with these opacities here
Yep. Yeah,
representing
that's right where I
septal
came in.
lakes. Okay. Okay. Yeah. So, you know, there's a differential diagnosis for that. But what's very interesting is, and here I'll put out the history. That's how she presented to the outside hospital. They thought tree and bud opacities. I mentioned, no, we don't have tree and bud opacities. And they didn't really quite know what's going on. They started antibiotics. And then a little bit later, you can see here that someone got the history of known exposure to rodent droppings at a campground. And then sure enough, they sent off for antibodies to Hantavirus, which is the next image, which is that. And we have positive for IgM and positive for IgG.
Wow.
So very consistent with the hantavirus pulmonary syndrome. It's certainly the most dramatic example I've seen of interstitial lung edema without alveolar consolidation. But at least based on this information and the fact that the patient didn't get sicker and actually got better, goes along very nicely with the hantavirus pulmonary syndrome. And the idea is, I think, that something about this syndrome is that's interesting is that it produces a permeability form of lung edema. So it's a form of acute lung injury edema. I don't know what it is about the hantavirus compared to others, but it's well described as producing a so-called pulmonary edema type picture, right? Yeah.
It's a great example.
Yeah. Okay. Next case is this patient, and let's go back to, and I'll show you the information in a little while, more information, clinical information. December 2024 looks okay. Let's actually have a look at 15 days later when the patient has some symptoms. So again, back to December of last year. And we have a relatively sparse, ill-defined, subsegmental sized opacities in the lower lung zones, ground glass attenuating opacities, but certainly sparse down there at that time. I don't know how sick the patient was, but I'm going to show you some follow-ups for that. So that's in December. I'll leave that up and we go forward to March on the right-hand side. Again, we see more opacities. These are consistent with areas of consolidation, multifocal, multilobar, patchy, quite extensive here, very extensive, involving all lobes. No signs of interstitial edema, no pleural fluid, just these pulmonary opacities consistent with consolidation. So certainly just based on this, multiple differential diagnoses exist. It's not suggestive in my mind of any particular thing, and one needs more information. But let me go forward in time now from March to, I've got a lot of images here, so let's go to April. And in April, we'll see that it looks a bit different, but it's certainly no better. In fact, in some areas, there are more confluent opacities. Looks like that. And the lung bases look like that compared to before. So certainly a progressive, non-resolving pulmonary disorder. So as I'll show you in a moment, around about that time, they got a history of arthritis, or at least joint pains, and maybe a rash that developed. So certainly if we get that history and nothing has panned out clinically since then. We're thinking of the possibility of a connective tissue disorder. And then we would think of pathologies in that context, such as organizing pneumonia, cellular NSIP, combinations of the two as a manifestation of a connective tissue disorder. And then I'll show you some more history in a moment, but I will show you how this progresses over time to really end-stage lung prior to transplantation. That has this rather unusual appearance. It's obviously progressive diffuse lung disease now. The appearance has changed, but perhaps no surprise that this is progressing, and the patient is then evaluated as a candidate for transplantation, and he underwent transplantation. So relatively rapid progression of the pulmonary disease over a period of months to this appearance. So again, to put this in context, at some point they didn't know what was going on, but you'll see here that they treated him. At some point they got broad spectrum interstitial lung disease panel, came back with anti-MDA5 antibody high positive in a patient with this presentation. And then somewhere in here I saw something about somewhere, maybe I didn't put it there, but arthritis, or at least arthropathy, and some a skin rash. Maybe I didn't copy that in. Oh, here, rash and arthritis. So anti-MDA5, I don't know about this lung pathology where you can see NSIP cellular and fibrosing variants. I don't know about the DIP-like and alveolar proteinosis reactions, what that means pathologically, but certainly consistent with a rapidly progressive pulmonary disease, consistent with anti-MDA5 antibody. Any comments about this rather somewhat strange pattern? And if you didn't have what looked like before, it would be hard to suggest any particular thing once you got to this stage.
I mean, that's like even the first images, it looks very peribronchial. You often see this like with anti-synthetase syndrome too. I think the pathology, we rarely biopsy them, so
Yeah.
it's unusual to see it. But it's like you said, it's a mix, often organizing lung injury, but there's often rapid development of fibrosis. So over time, it starts looking like like a more typical NSIP, but you have this thicker stuff around it that you sometimes see with an anti-synthetase. But when I see a rapidly progressing acute lung injury like this, that's one of the things I think about is I know amyopathic myositis. Now the rash in this case helped, but sometimes they don't have any of that. And then there's the whole extended myositis panel now that has a bunch of different things they can test for.
Yeah. So a pretty dramatic case of that bad thing, anti-MDA5, which is well described as producing a really bad and rapidly progressive pulmonary disorder. Yeah. Okay, and the last one is just sort of, this is just a bit odd. I saw this case, and at a first glance, here's the lateral. I see screws, ribs, but without plates, and I'm not used to seeing that. So I did in fact get a history, at least based on the history in the note that I had to find, talked about screw fixation of multiple fractured ribs, but without plates. And this is the first time I've seen that, so I don't quite know. These screws must transfix fracture fragments, and just dozens of screws in multiple ribs, but without plates. So that's pretty unusual. First time I've seen that particularly. So certainly a curiosity. I don't think we see that anymore. Have you ever seen screws without plates? It's odd.
No.
Yeah, don't know what to make of that. It's just that's what they did.
I'm not sure what holds everything together.
Yeah.
Since they're constantly
exactly.
moving.
Yeah, you just put
Little-
screws across fractures like that
Some super glue.
in pairs or something. So I don't know. Not likely to see this again. So just a curiosity. Okay, those are my cases.
Nice.
All right, thanks, Howard. All right, whoever would like to go, feel free.
I have two quick ones that I can do. Let's see. Share this. Share. Okay. Hopefully you're able to see a radiograph
Good.
and a CT. Perfect. Okay, so this is a case that I came across recently, and it's not really, a diagnostic conundrum or anything like that. I think it's just a really nice, classic example of something that we see not super frequently, but something I feel like I don't know that I ever really thought about or heard about that much in medical training. So in this radiograph, we obviously have a patient, they've got a port, they've got essentially complete whiteout of their right hemithorax, and we notice that their trachea is pretty significantly deviated, right? The carina is over here at this level, right, off to the left-hand side of the spine. The heart is being pushed over as well. Just as a comparison from this same person earlier the same month. This is off of a scout, but this is what their chest looked like, right? Well, they obviously not normal. They've got, some pulmonary nodules and masses to go along with the malignancy that they have. Their trachea was, perfectly midline, nice normal position of their carina. And again, this is what they look like now. And they are coming into our acute care clinic with significant shortness of breath. And here's their corresponding CT, right, which I think, as we sort of suspected or expected, shows this very, very large pleural effusion on the right, complete collapse of that lung. You'll notice again that the trachea is pretty significantly deviated and actually compressed by this very large effusion. And I think this is actually even more impressive in the coronal view, because as we come to this, you will notice that this very large effusion is actually inverting the hemidiaphragm and pushing the liver down. Yep. So I think just a nice sort of classic example of tension hydrothorax, which again is not something that I really thought about all that much or heard about all that much until I went into radiology. I think we talk about tension pneumothorax quite a bit, but you obviously can get the same sort of problem with fluid taking up that space and causing compression and obstruction of various body parts, right? We can see that there's quite a bit of mass effect here also on the right atrium, which is pretty significantly narrowed here. So yeah, just an unfortunate but classic example of this pathology.
Yeah. Mm.
Yeah. And then my other case, which I think is probably clinically not that relevant, but I thought just is like a very cute imaging finding or an interesting imaging finding. So 2 radiographs on the same patient. These 2 radiographs are about 5 years apart. On this older one over here, we can see, a nice anatomic variant where we've got this nice little azygos fissure with a little teardrop of the azygos vein at the bottom of it. And on their more recent radiograph, we still see a little bit of that fissure, but that little teardrop of the vessel is not really as clear or as clearly seen. And the reason for that is that this patient recently had this very large pneumothorax. And we can see here that azygos vein sitting in its little sling of a fissure where it was previously. And so very large hydropneumothorax. They treated this with a tube. And after the lung had re-expanded, here's our little azygos fissure, but the azygos vessel itself has actually, when the lung re-expanded, it sort of pushed the azygos arch back into the more conventional position. So it's no longer sort of sitting in its little accessory fissure.
It's an escaped azygos vein.
Right, yeah. I just hadn't seen that particular change before, and I thought it was a nice example of it.
I've also seen an empty azygos fissure with the azygos in its normal location with no history of pneumothorax or surgery or anything. So maybe even maybe embryologically during development, it pops out.
Yeah.
But it just illustrates the point that the vein is technically not in the pleural space, right? Because it's
Right.
extra pleural.
Mm-hmm.
Yeah, there's a couple case reports of that pre and post.
Nice.
It's cute. That's a nice one. Yeah, I think it has zero clinical relevance.
Yeah,
Yeah.
absolutely. It's just a
It's
like fun
fun
image.
though. Hey, Jeff and I prospectively called a displaced azygos vein in a patient who was going to undergo right lobectomy for lung cancer,
Love
and
it.
saved it until I got the follow-up study and saw that it had popped out.
Amazing. That's great.
Yeah,
All right, those were my 2 quick
very
cases.
nice.
Travis, do you have any?
Yes.
All right. So this is a impressive case. This is a cool case for 2 reasons. The pathology is very interesting, but also it has some neat physiology / artifacts. So this patient has a history of remote tuberculosis and presented with hemoptysis. And you can see here, there's this big blob. I'll go to the lung windows. You can see there's what looks like a giant Aspergilloma, and it has a little couple of friends and neighbors down here, and all this cavities, bronchiectasis. So probably the cause of the main issue is these things. But what's cool is see this bright contrast here. So if we go up a little down here, you can see the bronchial artery circulation is quite large. We are very on a levo phase here, right? So there's like hardly any contrast in the pulmonary arteries. But we actually see I shouldn't say, we see filling of the left pulmonary artery with this dense contrast that's coming from anastomoses with the bronchial circulation. So this is an example of white smoke, as we described in our article about it. So it's bronchial artery inflow, but we're on the systemic circulation here. And on the delayed images, you can see it's not there anymore. So I thought that was really cute, just because it's pretty striking just how much reflux there is in there. And you can see there's slow flow, there's smoke in the superior vein from reduced pulmonary arterial blood flow, and you can even see some mixing artifacts in the vessels in the pulmonary artery as well there going down. So a really bad Aspergilloma mess here with some bronchial artery hypertrophy and collateral flow into the pulmonary circulation. I don't think I've seen one that pronounced.
That's great.
Yeah, this next case is a good case for differential diagnoses and thinking about radiographs. So this patient here has this radiograph, and you can see there's this mass on the left. It's lobulated. It's quite large, and it also looks pretty dense in a few areas. So, of course, having a lateral is quite helpful in that you can see that it is clearly outside the thoracic cavity. So it's something in the chest wall, and you might be wondering if this is some kind of sarcoma. Is this a benign bone thing? And this thing has been worked up a lot, but I just came across it and saw it was a nice radiograph. But here it is on here. If we switch, let's find decent. None of these windows work. Let me find a better one. Oops. There we go. You can see it's in continuity with the marrow space here. It's very sclerotic. There's no periostitis. So this is actually an osteochondroma. A lot of osteo in it. So it's a benign lesion, but it's kind of a fun radiograph, because if you don't have the lateral, you might think it's a hilar mass or something, but looking carefully, you can maybe see the vessels going between it there. So I haven't seen one this big before. And your differential, of course, is an chondrosarcoma, but this one was not, and it's been stable for a long period of time. So kind of a cute radiograph.
Yeah.
This is a cool case. So this patient a young patient had ALL in childhood, ended up getting a bone marrow transplant, and then developed chronic graft versus host disease. And from that, constrictive bronchiolitis, so severe airflow obstruction. And you can see on this chest CT, there's bronchiectasis. Surprisingly, this is actually a lot of air trapping. And then had this thin cystic space with a little bit of stuff in it right there. And this was immediately before a lung transplant. So this patient went on to get a lung transplant for severe obstructive lung disease. But you can see all of this is air trapping. I don't have expiratory images, but I'll show you a sagittal. You can see how hyperinflated this patient is. So this is the explant. So this was constrictive bronchiolitis on explant. There was also a little bit of PPFE. So presumably some of this stuff out here. It was pretty modest, but there was some PPFE. But this ended up being a little Aspergilloma. And then this is the 58-year-old woman who carries a diagnosis of progressive massive fibrosis. She's got these large masses. You can see there are there we go. They are calcified in the middle. There's really no lymph node enlargement or calcification, but if you look on the background, there are small little nodules, some along the fissures, so some perilymphatic nodules here. So the differential is sarcoid, and then of course pneumoconiosis, a couple larger nodules. So it turns out she worked in a tire manufacturing factory for many, many years, and they do actually use silica when they make tires as a filler to mix in with the rubber and stuff, so they don't have 100% rubber, because that would be very expensive. So this is silicosis, and it's only the second case I've ever seen in a female patient. One was a ceramic worker, but this is silicosis with progressive massive fibrosis from tire manufacturing. Yeah, so that's just kind of a neat one. I don't have a radiograph, unfortunately. This is a 10-year-old who presented not doing well and has this massive pleural collection here. And you can see it's got some significant mass effect on the heart. There's pleural thickening enhancement. So in a kid, of course, you think about infection before tumor, but of course, you could have a malignancy. Well, I think what's helpful in this case is there's also this abnormality in the liver. There's this area of low attenuation with this other area around it, this multiloculated cystic thing. So they actually drain this presumed empyema, and this is a tuberculous empyema with liver involvement as well. I couldn't find any pulmonary or skeletal involvement, but TB empyemas can get quite large, and of course, TB can affect other organs. So this is a TB empyema with a liver involvement.
Wow.
And then this is probably the most interesting case. So this is a woman who was being evaluated for some renal masses. And she's got all of these tiny little nodules in the upper lobes, predominantly. They're ground glass. But they're not, some of them are a little bit bigger, right? 5-6 millimeter range. And there's not a lot of them, but you see them around here and there. She's a non-smoker. And there's even a few down here. So this is not typical of LCH, but that might be one thought. One of my trainees thought about meningothelial-like nodules, but for me, they're too big, and some of them are too well defined. She's also too young. She's like 20-something. So the clue is, if you look at the bones, and I'm going to get this window right one of these days, there's all of these little sclerotic foci in her bones. I'll do a sagittal of the spine. You can see them better. I'll thicken this up a bit. Come on.
Nice.
Yeah. So any ideas, guys?
Yeah.
MMPH?
Yep.
Yep. Good. Yeah. So I confirmed she has tuberous sclerosis, and this is presumably multifocal micronodular pneumocyte hyperplasia. She does not have LAM. I didn't see anything to point to LAM. I looked for fat in her myocardium, but the osteopoikilosis and a bunch of kidney masses fits with tuberous sclerosis. So yeah, I only seen a few of these cases. People describe ground glass with LAM. I suspect that's what it is, but we just don't see it very often. And I've only seen it with tuberous sclerosis associated LAM. But this one is the first time I've seen it without the LAM. So
I remember the first case of MMPH I saw as a fellow was a male patient they were following that had a bunch of ground glass nodules in the setting of tuberous sclerosis. But that paper from radiology that talks about the bone islands or the sclerotic bone lesions differentiating tuberous sclerosis from sporadic LAM is really helpful for cases like this.
Yeah, exactly. I also think the fat deposits in the myocardium are probably, I've never seen one that was not in TSC LAM. So
I tried to look that up in haven't found anything about that in the literature. I mean, I totally agree with you.
Yeah, it's not, no one's described it. Problem is there's such a rare disease, it's hard to get enough cases to prove it. But it makes sense because you don't usually get the various cardiac manifestations of TSC with sporadic LAM. So yeah, presumed MMPH.
Very nice.
All right.
Yeah.
So yeah, I think that's all of yeah, that's all I got this week. So interesting collection of cases, but
It's great.
yeah. So Howard, on that hantavirus case, I meant to ask you, were there other reported cases from that same location? Was there any outbreak, or was it an isolated case?
I didn't get